Thank you for joining me today for this video as we start talking about abnormal kidney function. I will mostly be giving a high-level overview again, since there are many topics that are covered here that rightly deserve their own hours-long discussion. We will primarily be focused on acute kidney injury in this video, and there will be a separate video on chronic kidney disease. Let's first go over how we detect abnormal kidney function, usually through blood and urine tests. Then we will be discussing the differential diagnosis to acute kidney injury and how we work up AKI. In another video, we will discuss chronic kidney disease and changes that we can see with patients having chronic kidney disease. Most patients with kidney disease don't usually have symptoms, and it's only because we draw blood samples routinely on patients that we can detect abnormal kidney function. In fact, many patients who come to see us in clinic are feeling well and may even deny that they have kidney disease just because they are wanting to associate some negative symptom with a disease process. Alternatively, they may associate kidney disease with chronic lower back pain. But in the absence of kidney stones, kidney disease is not typically associated with pain, and back pain is usually musculoskeletal in origin. The most common way we detect abnormal kidney function is through abnormal creatinine values. As you know, the creatinine value is a good surrogate marker of kidney function, as we discussed in a previous video. The calculations to estimate glomerular filtration rate can help us to get a better idea of what an individual's kidney function is. Additionally, the urinalysis is also helpful to detect specific types of kidney injury. Normally, urine should not contain any protein or blood products, so if there is evidence of any of these substances, this may be a clue that there is something wrong with the kidneys. Of course, there are other reasons to have red and white blood cells in the urine, so exclusion of a urological issue or infection must be done first before we start working on patients for renal issues, since urological issues are much more common in the general population. The specific gravity is a number that is usually overlooked, but can actually be very helpful to determine if a urine sample is very concentrated or dilute. Most patients will have a specific gravity of about 1.010 or 1010, but a higher specific gravity of, let's say, 1.020 or 1020 or above can actually suggest dehydration in these patients. One thing we must try to distinguish is between acute kidney injury and chronic kidney disease. While the risk factors for both are similar, acute kidney injury usually portends a better outcome compared to chronic kidney disease. Many times, patients with acute kidney injury can recover, even those who end up on dialysis. Of course, the main difference between acute kidney injury and chronic kidney disease is the duration of kidney injury. For patients who have a drop in kidney function for 3 months or less, we typically would consider this an acute kidney injury compared to durations of longer than 3 months, where this is usually considered chronic kidney disease. Since the time course is important at distinguishing AKI or CKD, it is always important to regularly test patients' kidney function during that time to determine the trajectory and any evidence of recovery a patient may have. Over time, prolonged AKI can result in chronic kidney disease, and both AKI and CKD have been associated with poor outcomes such as cardiovascular events, dialysis dependency, disability, diminished quality of life, and death. Once we establish somebody as having CKD, our job is to control modifiable risk factors such as hypertension, diabetes, and metabolic syndrome to decrease the risk of progression of kidney disease. Additionally, monitoring proteinuria and adjusting medications to minimize proteinuria is helpful at also reducing the risk of kidney disease progression. So how do we practically differentiate AKI versus CKD? The first step when assessing abnormal kidney function is to see what their baseline kidney function is. And this is typically done by assessing the baseline creatinine levels when they're available. Once we determine what a patient's baseline kidney function is, then we can determine if the patient has an acute kidney injury or not. In reality, when you are seeing patients without previous lab tests, or if the lab tests are from a very long time ago, it may be difficult to establish this baseline level, and you may need to closely follow this patient over time. Let's take these two examples here. In the first case, this young man's creatinine has increased from 0.8 to 1.4, and the calculated estimated GFR has decreased from 116 to 65, which signifies an almost 50% decrease in kidney function. Conversely, this older man in the bottom example has an increase in creatinine from a baseline of 2.8 to 3.4, which is the same increase of 0.6 as the young man before, But this time, the GFR drop is only from 22 to 18, which is less than 30% of a kidney function drop. Are both of these significant? Yes, absolutely. But I'm much more concerned about the larger drop in the younger patient compared with the smaller drop in the older patient. Once we get an idea of the severity of the drop in kidney function, we can now try to figure out why the patient's kidney function dropped. In general, we can split the causes of acute kidney injury into 3 different categories: pre-renal, intrinsic renal, and post-renal. For pre-renal, this is usually some drop in effective arterial blood volume that results in a decrease in blood flow to the kidneys. Any fluctuations in blood flow can affect the kidney function, and if significant enough, can result in temporary kidney injury. Intrinsic renal etiologies encompass quite a range of issues that we will discuss in the coming slides. And finally, if anything obstructs the outflow of urine from the body, this can result in kidney injury, similar to when your sewer backs up in your house and you've got waste coming out of your second floor toilets. When kidney injury from obstruction happens, you want to make sure you clear or overcome any obstructions quickly to maintain good functioning kidneys. Let's talk a little bit more about pre-renal etiologies. Again, this is usually due to a decrease in effective arterial blood volume, which is the blood volume that is sensed by the kidneys, typically due to a decrease in perfusion. Recall that the kidneys filter up to 20% of the patient's cardiac output, so any change in the blood flow to the kidneys can lead to a significant change in perfusion to the kidneys. Usually the decrease in effective arterial blood volume happens when a patient is volume depleted or losing blood, such as in the case of trauma or sepsis. However, remember that a physiological decrease in effective arterial blood volume can actually happen when patients are volume overloaded too, specifically in decompensated heart failure and liver failure. This is the reason why it is important to take into consideration the volume status of a patient and underlying issues, since the information can help you know how to treat these patients best. In the setting of blood loss, you'll want to give the patient blood or more volume, but in the setting of volume overload, you'll want to use a diuretic to get that excess fluid off and move the patient to a better part of the Starling curve and potentially increase their cardiac output in the setting of heart failure. Also know that if poor perfusion to the kidneys is sustained for long periods of time, this can lead to ischemic damage to the tubules and intrinsic renal damage that we will discuss later. We do have ways to help us determine if a patient is volume overloaded or not, and this is with the fractional excretion of sodium calculation. It represents the percentage of sodium that is filtered by the kidney that eventually is excreted in the urine. In normal settings, the excretion of sodium should be about 1%, but in the setting of acute kidney injury due to pre-renal etiologies, the kidney will want to avidly reabsorb the sodium and the FeNA value will drop to less than 1%. Conversely, in the setting of intrinsic renal diseases, there is usually some damage that prevents reabsorption of sodium, leading to sodium being inappropriately excreted, and the FeNA may be typically greater than 2%. There are some limitations to using FeNA equations, specifically when we are using diuretics, which can affect the sodium reabsorption of the tubules. In this case, you can use a fractional excretion of urea, which is the same calculation of FeNA except with urea substituted for sodium. Here the cutoff is 35%, so if the Phe urea is less than 35%, this would be suggestive of a pre-renal etiology, but if greater than 35%, this may be suggestive that there is some sort of intrinsic renal damage there. When there is any doubt of a patient's volume status, whether they're depleted or not, it is usually reasonable to give a patient a fluid bolus or challenge, and if the kidney function improves, then the patient was most likely in a pre-renal state. And if the patient doesn't get better, then it may be that there's some sort of intrinsic damage or pre-existing chronic kidney disease involved. As a clinical pearl, the FeNA or Phe urea is not helpful in the setting of volume overload, since a low FeNA or Phe urea would help you to determine if you're going to give the patient fluid or not. In these cases of volume overload, you'll probably want to remove excess fluid or diurese the patient instead of giving them fluids. So the diagnostic test of the FeNA or Phe urea may really not be helpful in the setting of volume overload. Post-renal etiologies are usually some anatomical obstruction that has occurred in the urinary tract after the kidneys have produced the urine. In this case, an ultrasound or CT scan will be helpful to determine where the obstruction is located and what procedures need to be done in order to decompress the urinary system and allow the urine to flow out of the body. We see a lot of stones, prostate issues, and malignancies where I work here at the VA. But in younger patients, there could be anatomical abnormalities that result in obstructions that can lead to significant kidney injury. We mainly work with our urology colleagues to help with treatment of these conditions, but sometimes interventional radiology can also help with percutaneous nephrostomy tubes that are placed into the kidney from the patient's back in order to access the urinary tract. And this is especially useful when the obstruction is high up or close to the kidney. When we talk about intrinsic renal disease, we can think of the 4 different areas of the kidneys, and this can help us narrow down our differential diagnosis. These areas are the glomerulus, the tubules, the interstitium, and the blood vessels. Injury to any of these parts can cause an acute kidney injury, and usually we can look at the lab tests to get a clue as to where the injury has occurred and to get a better sense of prognosis for our patient. Let's first start with glomerular etiologies of AKI. In glomerular injury, we usually have both proteinuria and hematuria due to podocyte or basal membrane damage that allows these larger molecules to leak through. Because they still have to squeeze through a small space, the red blood cells usually are deformed and are what we call dysmorphic. When we look at these red blood cells under the microscope, the deformity helps us to distinguish between a glomerular cause of bleeding and bleeding from the lower urinary tract issues. There are many glomerular diseases that can lead to chronic kidney disease, and they can range from more benign cases, such as minimal change disease, to more severe cases that lead to rapidly deterioration of kidney function, also known as rapidly progressive glomerulonephritis, or RPGN. Most glomerular etiologies of acute kidney injury will be relatively severe damage, such as part of a systemic illness. In these situations, it is always helpful to get us involved earlier so we can perform proper workup and start aggressive treatments for these patients to prevent permanent damage to their kidney function. Tubular injury is the most common cause of intrinsic acute kidney injury and is usually the result of renal ischemia from hypotension, sepsis, or surgical issues. Additionally, certain medications and diagnostic studies, especially CT scans done with iodinated contrast, can cause renal tubular damage to the kidney. We usually term these nephrotoxins, and in the setting of persistent kidney disease, either with AKI or CKD, you'll want to try to minimize exposure to these nephrotoxins to prevent further damage and progression of kidney disease. When it comes to interstitial etiologies of AKI, these are usually manifested through what is called interstitial nephritis, and the majority of these are essentially allergic reactions to medications that are manifested in the kidney. The hallmark of interstitial nephritis is a neutrophilic infiltrate in the kidney that is easily seen on kidney biopsy. There are some medications that are known to cause both acute and chronic interstitial nephritis, including NSAIDs, proton pump inhibitors, and some antibiotics. Additionally, there are some infections and systemic diseases that can also present this way as well. The classic triad of fever, rash, and eosinophilia may be present, but these happen in actually less than a quarter of patients that have biopsy-proven interstitial nephritis. As with any allergic to medications, it is important to remove the offending agent as quickly as possible to try to suppress the reaction, and you can also give steroids to suppress this reaction as quickly as possible, as long-term nephritis can predispose to chronic kidney disease. With regards to vascular issues, these are commonly split into large and small vessel issues. The kidneys are filled with blood vessels, so they are very sensitive to any damage to the vasculature. Large blood vessel issues can present similarly to pre-renal etiologies and can result in tubular damage over time. These include fibromuscular dysplasia, atherosclerosis, and large vessel vasculitides that you will no doubt learn about in your rheumatology block. In small to medium vessel issues, these can sometimes present similarly to glomerulonephritis, such as small vessel vasculitis, cholesterol emboli, hypertensive changes, and diabetic changes. So now we've gone through the differential diagnosis of acute kidney injury. What does the workup actually look like? After we have assessed the patient's baseline creatinine level and assessed the trend, we can then order urine, blood, and imaging tests to help us narrow down the location of the kidney injury. A renal ultrasound is always helpful to rule out post-renal etiologies and obstruction that results in acute kidney injury. Other imaging studies, such as CT or MRI, can be done, but ultrasound is usually the fastest and most convenient to obtain. It can even be done at bedside. The urinalysis is also helpful to determine if there's any protein or red blood cells and can give us a clue if there is any glomerular or interstitial etiologies to their acute kidney injury. And there are other serological tests that we can do to help narrow the differential diagnosis. It is important to remember that hematuria and proteinuria, especially gross hematuria, is commonly found in urological issues, so one should always rule out lower urinary tract issues first before attributing proteinuria and hematuria to the kidney. When in doubt, do give us a call and we can help determine what the next steps are in the workup and management. Lastly, the urinary sediment can be very helpful at differentiating the causes of acute kidney injury. So what exactly is a cast? A cast is made up of protein called Tam-Horsfall protein that gets solidified in the setting of stagnant urine. If there are other things in the tubules like blood cells or remnants of cellular structures in the setting of cell death, then these can get stuck in the Tam-Horsfall proteins, much like blueberries in a muffin mix. A hyaline cast, seen in the upper left, is essentially the Tam-Horsfall protein that is solidified in stagnant urine without any additional elements, basically your plain vanilla muffin without anything inside. When red or white blood cells get stuck in with the Tam-Horsfall protein, we get RBC or WBC cast, which can be indicative of glomerulonephritis or interstitial nephritis, respectively. An RBC cast is seen here in the lower left, and the white blood cell cast is seen here on the lower right. On the upper right, we see a muddy brown cast, which is the necrotic fragments of renal tubular epithelial cells that have died in the setting of acute tubular necrosis, or ATN. While you won't see these features all the time, the presence of these casts can help us narrow down our differential diagnosis and determine what pattern of injury a patient has and can lead us down our next diagnostic step. I know that's a lot of information covered in today's talk, but feel free to rewind and review any of the topics I covered. Again, this is meant to be a very high-level overview since we can spend hours on individual topics within AKI, but I hope this gives you a general sense about how we think about patients with acute kidney injury. As a reminder, we covered how we detect kidney disease with urine and blood tests. We then talked about the difference between AKI and CKD, and then we discussed the different areas of the kidney and how these could cause kidney injury. Lastly, we discussed what the tools are we can use to help us diagnose the cause of kidney injury. Thank you for joining us today and look forward to seeing you again in our next lecture on the management of chronic kidney disease.